Good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center, and welcome again this week to Facebook Live here at CGH. So I'm looking forward to chatting with my guest in just a few minutes today, Dr. Matt Cutter. He's an optometrist here at CGH. I think you're going to enjoy that conversation. But before I get to Dr. Cutter, I wanted to hit a few COVID-related items first, and I'm going to do this in the format of things that we do know and things that we don't know in terms of COVID. So, do know at CGH we have tested 21,462 people. Of those tests, 3,507 have been positive. So around 15% of the people that we've. Is that right? No. That would be, yeah, okay. Anyhow, I didn't do the math, and I'm in front of you all. I don't think as well when I'm in front of you all, but anyhow, that's the test and the number positive. And I also do know that I didn't have my phone on vibrate. That's another thing I do know, but now it is. My apologies. Another do know, the number of cases in Whiteside County and Lee County have been higher than the state average for the past few weeks. Yesterday, for instance, we were at 5.1% positive testing, and the state average was 3.1%. The state average has gone up in the past few weeks as well, but we've gone up more so than the state average. The national COVID case rate, the number of COVID positive cases today was flat, which for the past 14 days. So number of cases is pretty flat from 2 weeks ago to now. And up until now, it seems like a couple months now that the trend has been, we've been going down in terms of the number of cases in the country. We also know that this UK variant, the B117, and others are spreading and beginning to take over from our original COVID virus that started here in the US. We also know that the UK variant, among others, spreads easier and causes more serious illness than the previous the original COVID virus that we had here in the US. We do know that we unfortunately have more sick patients here at the hospital in the last few weeks than we had for, 2 months or so prior to that. And as far as vaccines, we do know that more vaccines are becoming available. We gave 450 first-time doses this week at CGH. We're anticipating giving 400 first-time doses next week at CGH. We do know that there are other vaccines out there, and I strongly encourage you, be outside of CGH, to be looking for vaccines. We just want you to get a vaccine. Where you get it, we are perfectly fine with. Matt's going to put up here. Were you able to put that together, Matt? So this is, I just had Matt type in this is the Vaccine Finder website that I've been mentioning to you for a few of these broadcasts. And Matt just typed in the Sterling zip code and what places had available vaccine within, I think it was a 50-mile radius. I don't know if you can go any further up and down on that, scroll up and down on that, Matt. But if you scroll, all those things where it says in stock, looks pretty promising. So, there's a lot of places within 50 miles that have in stock stuff according to that website. So really encourage you to seek those out. I also know that before I got on here, typed in like Winnebago County has a mass vaccination site. And if you type that in and you enter your information, you can sign up to get notified when when you qualify to get a vaccine there. So I would encourage you to take advantage of all those. Of course, there's the full, everyone can get a vaccine is April 12th, but up until then, there definitely are buckets of categories for quite a few folks to fit in that would be able to get vaccinated. So I really encourage you to take advantage of that. Illinois, there have been, as of yesterday, 5,036,000 vaccines given. The rolling 7-day average is 97,680 vaccines a day. So we're getting there. We also know that masking and distancing and following those precautions really reduce anyone's rate of getting an infection, even if you're exposed to these variants. We do know also that more places, businesses and other places are open in Illinois than they were prior to the second surge in November and December. We know that that's happening right now. And we do know that how many people get sick from COVID and also how many people get really sick from COVID are dependent upon in the upcoming days, weeks, and months are dependent upon, from my perspective, 4 variables. And they're the 3 V's and a B. So the 3 V's are the variable virus. In other words, how many people have already had the virus and therefore have at least some significant immunity to it. Number 2, how many people have been vaccinated? And some of those people who have been vaccinated have also had the virus, but also how many people have been vaccinated and therefore are much less likely to get really sick. And we do know that even with these variants, that if you've been vaccinated, your likelihood of getting really, really sick is really, really low. Third V is variants. So in other words, as these variants begin to become more prominent, which ones become more prominent, and how do our bodies respond to those variants? And so that's a factor. And then I couldn't think of another V. So the 4th thing I came up with was behavior. So how we behave between now and when things have eventually settled down is the 4th thing that will determine how many cases and how many people get really sick in our area. Here's what we don't know. We don't know what's going to happen beyond what I just told you that we do know. I think I know for myself have the humility to say that those variables and the fourth thing, behavior, how that's going to play out in the next days, weeks, months, we don't know. So I think if you look really big picture, that we'll get through this. But for the foreseeable future, and for most of us as humans, the foreseeable future is now and a few weeks or months in front of us. I don't know. It's where it's going to play out even week by week as we have these broadcasts. What I would encourage 3 things. I would encourage when the opportunity presents itself and it's your turn to get vaccinated, and I would encourage you to encourage other people to do that as well. I would encourage you to follow the behaviors that we know reduce your risk of getting sick, particularly if you've come this far and you haven't gotten sick so far. Boy, I'd encourage you to continue to follow that and get that vaccine, and then you're going to be much less likely to get sick. And the 3rd thing is, within the parameters that we have, enjoy life to its fullest. So we can't do quite as much as we've been able to do in the past if we're following these precautions, but there are still things that we can enjoy and do, and I would encourage you to do that. Okay, that's COVID for this week. As always, if you have questions or comments, throw them our way. We'll be glad to talk about them here on the broadcast. But I want to talk with Dr. Cutter now, unless I have other questions that come from the folks who are watching. So, hi, Dr. Cutter.
How's it going?
It's going well. Welcome. I was asking before we got on, but that's perfect for an optometrist for a background. I said, is that a green screen or something?
Yeah, no, just my exam room. We have some telehealth, so we have to have a place to do it. So this works out nicely.
Perfect. So I like I think this is my favorite setting for a guest I've had, just with what you have there. So you set the bar high.
Uh-oh, yeah.
All right, so you ready?
Sure. Fire away.
Okay. So I know Dr. Cutter from a long time. And I know that when he was young, he was a BMX guy. He liked the bicycles and do the tricks on the bicycles and all that kind of stuff.
That's correct.
Right, Matt?
That's correct. Yeah.
Okay, so you had a fork in the road at some point in time in your life, and you had to decide, am I going to be a professional BMX rider, or am I going to be an optometrist?
Sure.
What happened there? How did you decide that you wanted to become an optometrist?
Well, there's no way my folks would let me be a professional BMX driver, for long. That just was out, But optometry was interesting to me. I remember when I got my first pair of glasses, and just the fact that all of a sudden I could see things. Things change so slowly for kids that sometimes you don't notice, and they don't have any way to tell anything. That's what I thought normal was. Put my glasses on, and it was just like I could see individual tree leaves and blades of grass and things that were just amazing me. So that stuck with me. And then also, honestly, the equipment. When I got my eye exam, the equipment was interesting. I thought it was just interesting things. So that's what kind of made me interested in optometry, and I just stuck with it.
Okay. Here you are. How long have you been practicing, Matt?
25 years, 26 almost now.
Yeah.
Mm-hmm.
I think you are in a rhythm. I think you've got it figured out.
Yeah, we've got it down pretty good. So, yeah.
All right. How much education does someone need to become an optometrist?
So it's 8 years. So 4 years after high school for a bachelor's, and then 4 years to your doctorate. There are residency programs available for optometry. They're not required, but if you're going to specialize, go into research or low vision or some of the specialized, then some people do a residency, which is another year, but it's not required.
Okay. Another thing I was just curious about. You're from Sterling.
Yes.
Yeah. So, two questions in that. So, was the plan all along when you got done with optometry school to come back to Sterling and practice? And two, what's it been like to practice in your hometown?
It was not the intention, in high school, like most high schoolers around here, Sterling, you always thought the big city had more to offer. You were going to go somewhere else. There was going to be more to life than here, and then you get off into the real world and you realize, these small towns are pretty nice, especially, I got married while I was in optometry school, had kids, and it was a nice place to have a family. So you realize the benefits of a town like Sterling. So that drew us back here. So it was a pretty easy decision to come back. So when I left, it wasn't, but after being gone for a while, it definitely made sense to come back.
Yeah. It didn't hurt that the girl you married happened to be from Sterling.
No, absolutely not. That's just it. So again, Christine's from Sterling. So, my family was still here. Her family was still here. Obviously, there's just a lot of reasons to come back to this area that made sense. And part of it is going along with what you said about practicing here. I see people every day that I've known since I was a kid. I mean, since they've known me since I was, in school as a, grade school. Actually, one of my staff members here, I went to grade school with her. We've known each other. She is a year older. Well, never mind. I didn't say that. She gets mad when I say that. But
you want to name names?
Yeah, well, but we've been in school together. I mean, since Lincoln grade school, so there is something nice about that. You drive around town and, all these places are places I grew up and did things, and people I see here in the office know my family, know me from a long time ago. It's nice. You're part of the community in a way that, really I enjoy that, So you also can't, I told my kids when they were growing up, they can't do anything either because everybody knows everybody. So there's a double-edged sword at time, but again, it's definitely a benefit. Yeah,
you bet. Okay, so I want to get into the meat of the matter in terms of clinical questions. And as folks are listening, if they have things they want to ask Dr. Cutter, please feel free and we'll answer those. First question is one that I hear about a lot, cataracts. So cataract-wise, how do you figure out if you have cataracts, and when do you decide, or when does the patient decide it's time to get those things repaired and fixed?
Sure. Yeah. So cataracts basically develop, all of us develop cataracts over a lifetime. Perfectly normal. We all get them. Nobody avoids cataracts. Okay. It's just whether they get bad enough to remove. And that really is driven based on symptoms, So you feel, how do you know, is what you're asking at first, is you basically get blurry. You say, I'm not seeing very well. You won't know it's a cataract until you come in and get an exam. And basically I see if I can make you see better. So if I can change your glasses, whatever, make you see better, then even though the cataracts are there, they're not a problem. Yeah. Eventually we get to the point where I can't make you see better. And so then I can't improve things enough, and they bother you enough that you say, you know what, I want surgery. That's how we decide when it's time. The little bit of wrinkle in that is your insurance company might not necessarily consider it medically necessary as early as you do. So you might say, hey, I can't stand this. But the insurance company until 2050 is kind of that magic number where they start saying, yes, it's medically necessary and they'll cover it. Before then, you could still get it done, but you would be covering it, which is usually cost prohibitive to most people. But it's symptom driven primarily. You know, I can't fix your vision and the cataracts are the cause, then it's time to have them removed.
Right. Yeah, I got it. And, you know, boy, cataracts is one of those things I would think for Dr. Hahn and Dr. Cundiff, who are our ophthalmologists here. You may talk about like you walk in and walk out and you go, hey, the world's a different place.
The surgery has made such strides. It is outpatient. You're in the morning, you know, you're at the hospital longer getting checked in and so forth than the surgery itself. And yeah, most of the time, depending on swelling, most time you go in with poor vision, you come out and you're like, things are brighter. Colors are the thing people talk about the most because your lens, the cataract, gets yellow. So it's like having built-in sunglasses. People come back and say, wow, the colors are so much more vibrant. I can, you know, people come back and say, you know, I didn't realize my walls were that dirty. I didn't realize, you know, things like that. So,
Next thing I wanted to ask you about was glaucoma. So what exactly is glaucoma and when should you get tested for that? Would you know you have it?
Unfortunately, you would not know you have it. It's one of those things. The only way you'll know you'll have it is you come in for an exam. There's no outward signs until it progresses a lot, you know. So if you came in and said, I can't see well, and it's because your glaucoma is advanced, we're way behind that. Okay. So unfortunately, you have to have an exam to diagnose glaucoma. But glaucoma is a disease where the pressure in the eye is high enough, it damages the optic nerve. The optic nerve is a bundle of nerves that make up the retina that connect the retina from the eye to the brain. The pressure goes up high enough, it damages that nerve. So the risk factors, then there's three main risk factors: the shape of your optic nerve, pressures over 20, and thin corneas. And there's a number of reasons for each of those. That's not necessarily as important, but those are things we measure at every eye exam. So when we do those things, we measure your risk of glaucoma. And then if you have enough risk factors, then we would do some very specific tests to diagnose glaucoma.
Okay. Is there an age when we should start getting screened for glaucoma, Matt?
We include it in every eye exam. If a child, when they come in for their kindergarten exam, number one, we look at everything we can. So we're going to look at the optic nerve. We don't measure corneal thickness necessarily, but we'll look at their optic nerve. And if I can measure a pressure on them, I will. If they'll sit well enough for me to put a drop in and measure the pressure, I'll start as early as possible. But it's included in every eye exam we do, every complete eye exam, that is, we always check those things.
Let's say it's somebody who's never needed glasses. They haven't needed glasses. They use readers, but otherwise wouldn't have any reason that they would come in to see you.
Sure. Eye exam wise, I recommend eye exams every other year until 40, and then every year after that, because the risk starts going up. Cataracts, glaucoma, macular degeneration all go up slowly over time. And I tell people all the time that even if you come in for your regular eye exam, that doesn't mean you need glasses, or it doesn't mean I'm going to give you glasses. We might refract, decide if you have a prescription, I'll give it to you and say use it if you want, because you can tell me how you're seeing. If you feel like you're seeing fine, no problem. But the health part of it, you can't tell me, unfortunately. So that's why we still encourage a yearly eye exam, good vision or not, because the problem is, like I said, with glaucoma, if you come in and all of a sudden, man, you've had glaucoma probably for years, and that nerve fiber layer is gone, that damage is there, it's not coming back. We can't fix it.
Okay, yeah. All right, I wanted to talk about diabetics and their eyes. What's the deal with them and the need to have them come in on a regular basis to get their eyes checked?
Sure. Diabetic retinopathy is the issue there. And a lot of people, you know, we talk about diabetes, we talk about sugar, you know, but diabetes, especially for the eye, is a vascular problem. Okay. And a lot of people don't think of it that way, but because of the blood sugar and it changing and getting pushed in and out of those vessels, the small vessels, which the retina is full of, become weak. And as they become weaker, they literally will leak blood in and out of them. So if you think about a hose, if you took a hose and poked a bunch of holes in it, the pressure is not going to be the same. So the blood pressure, the perfusion in that area will not be as good, simply because of the fact that the blood's not flowing through there well. That then leads to then damage to the retina, death of the retina, and so forth. So we look at diabetics then to see if the vessels are starting to show leaking or not. Most diabetics get some diabetic retinopathy, some brittle vessels. But if it keeps advancing and then we start seeing cotton spots or death of the retina, that's when it becomes more concerning. So that's why we look every year, unless we see more advanced, and obviously we'll do it more often, but at least once a year, because same thing with that. Those early changes have no outward sign. You have no idea they're there. If you came in and said, hey, I've lost vision and it's from diabetes, we are behind. We are definitely behind the curve then.
Okay. Good. We're cracking through these topics. This is great. So macular degeneration.
Sure.
So what is it? And is there anything that can be that we can do to prevent it? And also if we have it, to keep it from getting worse, or
Sure.
cure it?
Yeah. So macular degeneration, there's still a lot of research, and we've scratched the surface on it. We have some idea of what causes it or what related to the causes, but basically the macula, and this is something that's difficult to kind of grasp because it's a strange word. People think macular degeneration, macula is the disease process, like rheumatoid arthritis, like rheumatoid macula, the disease process. It's not. Macula is a place in the eye, and that is the center of your vision. That's the center of your retina where the cells are packed in the tightest. It's your best area of best vision. That's the macula. So you can have a lot of different things that go wrong with the macula, but macular degeneration is where the macula breaks down and the deeper layers break down, allowing then, lipids and fats and blood and other things from behind the retina to come forward into the retina, which then disrupt the retina, and that distorts your vision. So that's what macular degeneration is. We do know that sunlight plays a negative role. Ultraviolet light creates free radicals in the back of the eye. Those free radicals damage the retina. And so that plays a negative role in macular degeneration. We do know that antioxidants combat those free radicals. Antioxidants, lutein and zeaxanthin, are found at high concentrations in the retina, so we think those are preventative, which is why we recommend for people with macular degeneration certain vitamins, in particular lutein and zeaxanthin, that help then slow those changes. And those have been studied now for about 15 years, and they definitely show slower changes in people on those. It doesn't reverse it, it doesn't stop it, but they definitely progress less than people not on the vitamins. So sunlight protection, those vitamins are the things that we can do to help slow those changes. We also know there's a genetic profile that you have that makes you more likely to get it. It's not one-to-one, so if you have it, you'll get it, or if you don't have it, you're safe, but it is definitely more likely. And there are genetic tests that can be done to tell you that profile. We don't do a lot of them, truthfully, because they're not one-to-one. If it would be like, hey, if I got that test and it said I don't have any risk and I don't worry about it, we might do more, but you still have a chance of getting it whether you have the genetic profile or not.
Yeah. So let me go back to the eye thing. You're trying to prevent direct sunlight. So sunglasses outside. Do you need polarized, or is it okay just to wear sunglasses without polarized in terms of trying to prevent macular degeneration?
Sure. Ultraviolet light is the critical part in that. So you want something that is UV blocking, and usually it'll say on the glass somewhere 100% UV blocking. That's what you want. Ultraviolet light is actually clear. So if you say, we can't see it, so our glasses can be clear and block ultraviolet light. They don't have to be dark. So you can say, I have regular glasses, but I don't want sunglasses. We can put a UV coating in there that blocks ultraviolet light, and then it's just as effective as sunglasses, because it's ultraviolet light's the problem there. Polaroid blocks actually light that's been polarized off a surface, so it's good for glare, but that doesn't change anything as far as macular degeneration goes. So it's more the ultraviolet light.
Okay. And the other follow-up question, Matt, was if someone, do they ever take those vitamins that you're talking about, not once they have it, but to prevent getting it? Is there, what would you say about that?
Sure. Right now, all of the studies have been with people who have had moderate to advanced macular degeneration. So that's the only thing I can say with any certainty, because that's what the studies show. But you would think if it helps people with moderate to advanced macular degeneration not get worse, you would think it would be beneficial to anybody who's going down that path. Okay. The problem is to do a study that had just normal people without macular degeneration, it's just too big. So they just can't do it. So the difference becomes then is the quantity. You're talking about a couple hundred times the recommended daily dose. So I don't encourage people to take that much lutein, zeaxanthin, and so forth without it, because it definitely has to be processed. Your kidneys, your liver work on those things and process that. So I do still recommend a good multivitamin with lutein and zeaxanthin in it, sunglass protection, or just get it in your diet. But most people, green leafy vegetables is where that comes from: spinach, kale, collard greens, things like that. But most people do not get that in their diet. We eat very little meat, but I don't get enough green leafy vegetables to cover that. So I still take it in a supplement.
Got it. Okay. Well, I'll talk about kids and kids that have like lazy eyes.
Sure.
When like a grandparent or parents looking at a little one, when is a lazy eye something that's like, oh, that's just, not a big deal versus something they need to see it for?
Sure. So let me go back a little bit and kind of explain why that comes from. So amblyopia is what we're talking about, okay, which is a big term. That's why lazy eye becomes a more common term, but that's a broader term because it's not specific enough. So amblyopia, meaning the eye does not see as well, but that's because it didn't develop as well. So the eye develops, the connections from the eye to the brain develop from use. So when you're young, you're moving through the world and the retina is being stimulated and it develops. If you have one eye that's being stimulated more than the other because of whatever, because of an eye turn, so one eye's focused on the right thing, the other eye's not, because you have a different prescription from one eye to the other, whatever it is, if one eye is not being used as much, it doesn't develop as well. Those connections from the eye develop primarily up till the age of 6, some through our teen years, but at that around 6-year-old, that's when we get our most change there, okay? So it becomes a problem. So that's what then lazy eye or amblyopia is. Those connections didn't develop. Just one eye not seeing as well, okay, or a little bit of a turn that is occasional won't necessarily create amblyopia, because if both eyes are being used, or if it's only turned partially, or some of the time, so that way they're both being used the majority of the time, that won't develop amblyopia. So that's the part that when you decide whether it's an issue or not. And the only way to decide that truthfully is get an eye exam and see how well they're seeing. And if both eyes are developing normally and they're developing fully, they're working well together, then we don't necessarily need to do anything about a little bit of a turn or a part-time turn, or again, a small prescription that might be a little bit more in one eye than the other, so forth.
Okay. What age do you start doing that at, Matt?
So we see, if there's a family history of problems, or there's a reason, like you see a turn, some reason that you want that checked, we'll check babies as young as newborns, but really for amblyopia and these type of things, the eyes don't focus well, they don't function well, just like anything else when they're young. Usually after a year, we start looking at that closer. Prescription has to be pretty large for us to give a child at 1 glasses. But again, we will look at them to see if there's a significant prescription one way or the other. And then it kind of keeps going from there. We definitely want to see kids before they start preschool or school or kindergarten, because then they're at the 4 and 5-year-old range, because if there is something that's there that was unnoticed before, we can start treating when we get, again, some effect on that.
Yeah. And I know from my own family members that it is a big deal, because if you get to that age where you're 4 or 5 and you haven't used one eye, you, as life goes by, your ability to like the 3D kind of stuff as stuff comes towards you, it's hard to do that. That's
correct. The further away it gets past 6, the harder time we have to make that eye develop those connections. The other eye's got a 3 or 4 year head start, so it's just harder to come back. The problem is sometimes, unfortunately, even if one eye has so much more prescription, even with best correction, it still won't be as good, but we still can make it much better than if we did nothing. Yeah. And I don't want to say, every month, but a couple times a year, I'll get someone comes in. The last one came in and wanted me to correct their one eye better because they were going in the Air Force and they'd been accepted and they wanted to be a pilot. Unfortunately, because they had amblyopia, we had tried, correcting them, and they didn't, which some kids just don't want glasses, and I get that,
Yeah.
And they put both eyes open, they see just fine. So they think, what's the big deal? They don't notice any difference, put them in glasses, and they think, I don't see any better because this eye's doing all the work.
Yeah.
But he was 18. It was not, we can't correct it. It's like, I'm sorry, but, and there goes his hopes, just at that moment. And so, it definitely can affect you in the future, and we can't, at this point in time, turn around and fix it.
Yeah, he went from being a pilot to being a mechanic.
Really, yeah. I mean, he's going in the Air Force, but yeah, pilot's out. So
yeah, got it. Let's talk retinal tears. Mm-hmm. So, how first of all, what are they, and then how would a person know about whether they might be getting one of those?
Sure. So the retina is basically like the film of the camera. That's kind of the analogy I use. So the eye's obviously a ball. Okay. The retina is how the retina fills the back cavity of it, and that's what we see with. That's light interacts with that, and that then sends a signal to the brain. That's how we see. So that is a thin film, and it's attached to the back of the eye, but sometimes it's loosely attached or has a hole in it or a thin area. If that happens, then fluid can get behind that. Fluid from inside of the eye's filled with fluid, can get behind that. It's almost like getting water on a wallpaper, and then eventually it builds up and it'll just then slowly pull away. Gravity or just the extra fluid can pull that away. That's actual retinal attachment. Most of those actually happen from the gel in the back of the eye, which as we age breaks down and separates away from the inside of the eye. As it does that, it tugs on the retina and causes the detachment. So you normally would get a shower of floaters and then flashing lights that you can't explain. When the retina moves all at once, it discharges all the neurons where our brain perceives that as a flash of light. So you say, I keep getting this flash of light I can't explain, or I'll look at all those floaters in there, or part of your vision blocked out like a curtain. As that retina comes off, you keep seeing this curtain climb up in your vision. So any of those things, flashing lights, floaters you can't explain, big sudden shower, those would be things that would concern us enough that you should call us and we'd look at you right away.
Yes, that's not something you sit on. Is that
no? And we all see floaters, a random floater. We all have floaters. We get more as time goes by. A random floater, random flash. Oh, I saw a flash. It was dark, and then I never saw another one. I'm not as worried about that. Or there goes a floater and it disappeared. You see those every once in a while. Anyway, that's not. We still would look at regular exams at that. That's not a call. It's emergent. But wow, look at all that stuff. I've never seen all that before. Wow, this flash just keeps going on. That's what gets concerning.
Got it. It's almost April, which means it's getting in that time of spring allergy season.
Yes.
So, eyes get affected by allergies. Any thoughts and suggestions for if you are someone who tends to get eye allergies?
Sure. If you get allergies routinely and you have seasonal allergies, you're really better off to start early on. Don't wait until they get bad, which is tough. We all do that. We all wait around and then all of a sudden it's like, wow, now they're really bad and I'm really rubbing them. Now that we're kind of behind again, so you're better off to treat it and keep it treated. And there are a number of what were prescription drops that are now over the counter. Pataday is now out in all three of their versions.
How do you spell that, Matt?
Pataday, P-A-T-A-D-A-Y.
Yeah, okay.
So Pataday, Zadidor, Z-A-D-I-T-O-R, and Alloway. Those are all allergy drops that were available by prescription that are now over the counter. And I almost always start with those, just because of the fact that if you can then just pick them up, you don't have to worry about calling for prescription, get them when you need them. It's easier, So I almost always start with those. If that's not enough, we obviously have stronger things than by prescription, and then I would transition to those if that didn't do enough. So, again, using them though daily helps them work better. That most of them don't work very well just by putting it in and it won't just then disappear. Keeping the allergies from flaring up and getting that strong is what we try to do.
Yeah. Okay, so something that I'm talking about some, chronic issues and stuff like that, but something that I'm guessing you and your office take care a lot of are people that have contacts.
Correct.
Eye inflammation from those contacts. What are some common reasons that people get eye inflammation from contacts, and what can they do about that?
Okay. So contact lenses, they're actually not supposed to be on the eye. Nothing's supposed to be on the eye. So we make contact lenses. We try to make them as inert as possible, but they're really not supposed to be there. So your eye can react to it for any reason, but it's more likely to react to it when it's exposed more. So the longer you wear them, sleeping in them, because obviously your eyes are closed, so that lens is on there touching the lid more, not cleaning the lens, so not digitally cleaning the lens, just soaking in solution, because it's building up bacteria. You take it out and you put it in the solution, you haven't wiped anything off of it, so that stuff will adhere to the surface. As time goes by, as those things build up, you're more likely to react to that. So that's what causes that. Sleeping in the lens in particular probably causes that more than anything else. Not throwing the lens away when you should. A lot of people say, well, I throw them away when they're bothering me. If they start bothering you, they are definitely way behind when they should have been throwing it out. If it's got enough bacteria and protein on it that it's your eyes reacting to it, it's too late. You want it well before that. So as some people say, well, I just change them when I need. I say, well, I'll change them 2 weeks before that then. So if it's been whatever your schedule is, move it up because you're doing it too long. But that's definitely the number one problem is not overwearing them, not cleaning them well enough, not replacing them when you should.
And another thing about contacts that I just think is interesting is over time, would you ever, if you really wanted to, could you find a contact to do about anything instead of having to wear glasses?
No, but for 90%, I would say, let me just throw out a number, I would say for most people, but it becomes the more things you correct, the more difficult it becomes. So if you're just nearsighted, farsighted, no problem. Almost 100% of those we can find a contact for, as long as you can tolerate contacts, that is, because that's then the next step. Some people can't tolerate contacts. Right. And then you add nearsighted, farsighted, add some astigmatism. That's one layer, a little more difficult, but again, we're correcting most of those pretty easily now. Then you go nearsighted, farsighted, astigmatism, and a bifocal. Now you're trying to correct a lot. It becomes much more difficult. So every time we add something, the odds of correcting it perfectly go down a little bit. Doesn't mean we can't correct it, but you might have some compromise. So I tell people with like bifocal contacts, if I can make you see well 80% of the time, and you say, this is pretty good most of the time, I would consider that successful, because they're not so good that I can make you see distance near and everywhere in between and every lighting condition. I wish, because then we wouldn't ever have to have the discussion. You just, here's your contacts.
Yeah, right.
But so again, more things we add, the harder it becomes to correct it. But it also takes time. So a lot of those things we can solve if you're willing to put in the time. 3, 4, 5, 6 different trials. Sure, hopefully we can solve it by the end.
Yeah. So you have to have if you want to go that route, you have to have the patience to be willing to.
Yes, and that's why usually when someone for bifocals in particular, we have a conversation about what to realistically expect about just the outcome, how well I can make you see, and the time it's going to take. Because some people at that point say, nah, never mind. I just thought I could throw something in and just not wear glasses. I wish, again, because then it would just be simple. I'd never have to have the conversation with people. It'd be just like, oh, here's your contacts and we're good.
Yeah, you know it. All right, final question. Who's your favorite employee?
So, yeah, thanks. It's funny when patients are in. So I have a technician that follows with me all the time, and that's because they don't trust me to work on the computer by myself. So it was before we had charts. I couldn't spell, or you couldn't read my writing, so someone had to write it down for me. Now they come in and they follow along. They really keep me going. So when someone in the office asks about the staff that was with me or whatever, I always say, whoever's with me, I say their name and I'll say, they're one of my top 3. And that's just, but it's true. They're all wonderful. So my technicians, so it's funny because I'm terrible with names, not my own technicians, but some of the staff here, we have a lot of staff in other offices and I forget names, so they always look at me like I'm going to forget their name, and I will mess it up sometimes, call them the wrong name because they're in the office. I'll say Mary when it's actually Stephanie or whatever. Yeah. But Mary, Stephanie, and Nellie are my 3 technicians, and I am blessed to have that staff work with me directly every day, because they really do. I've said this too, that, it takes a group to do this. Healthcare is complex now. It's not just simple. It's not just we write down a prescription on a note card and file it and you see the person next year. There's a lot going on, a lot of electronic records, a lot of, charting to do, a lot of outside influences. So you have to have somebody help keep that straight. And they do a great job. And my opticians, so Lisa and Kara, my end goal for a lot of people is make you see better. So I give you a prescription. Well, now all of a sudden you need glasses. Well, they don't do a good job. It doesn't matter how good of a job I did. So you need, good people around you. So my technicians, my opticians, keeping the schedule straight. Melissa and Mary, who are receptionists, do just a wonderful job with that. So again, I'm blessed to have the whole crew that I have that, so I don't want to pick one by any means, but I really am blessed to have
time. But yeah, I know you. I think a lot of our people that are watching this, thanks, Donna. Appreciate it. Appreciate that comment, Donna. Yeah, I mean, I think a lot of our listeners, you guys do a lot of people come in to see you all. I mean, you guys are a really busy business, so they know this, but I'm not telling them something they don't know. But when you go in to see yourself or Dr. Hahn or Dr. Kundus over there, you guys have a really good crew. They do a really good job. They take good care of people, and it's just.
And like I said, I'm blessed to have the group I have, because otherwise I couldn't do what I do. I couldn't see the amount of people we do. I couldn't give the care that we do. I mean, I rely on them to do a lot, and so I'm blessed that I have a good group that works as hard as they do, and we definitely have a system down. We've worked on it for 20 some years now, and I think it works well, and it gives me a lot of face-to-face time with the patients, so they get good care, and it keeps me from having to type in the computer and do those things that keep me from doing patient care.
Okay, good.
Yeah.
Well, hey, Dr. Cutter, it's been a pleasure. We've gone through a lot of stuff, so I think it's been good information for the folks that are watching this, and appreciate the work you do, and thanks for taking the time to chat with me this afternoon.
Happy to do it. Thank you very much.
All right.